Hi, everybody. Good afternoon. No, I was about to say happy Friday. It's actually happy Wednesday. Happy Wednesday. Thank you, everyone, for joining us. Sorry, we're a little bit late. We were just having some technical difficulties, but we sorted them out, so we're sorted. And I think because of that, I'm not going to fluff around much today. Let's just get going. Thank you, all of you, for joining us. My name is Sarah, and this is one of our series of regular series of Palliative Care Nurses Australia webinars. Today, we are going to change direction slightly from our clinical types of webinars and talk about technology and palliative care nursing. And I'm very, very delighted to be able to introduce to you a colleague of mine and that we actually nursed together 15 years ago at Peter Mac, and her name is Antonela Vogranic. Wave, Antonella. And I'll
Hello.
introduce her to you properly in a minute, but before we get going, we'll do an acknowledgement of country. So at PCNA, we acknowledge that we live and work on sacred lands of the First Nations people of Australia, and everyone joining us today will be on a different land in a different location. And I'm joining you from Darwin and the land of the Larrakia people. At PCNA, we honour, respect, and admire the Aboriginal and Torres Strait Islander people who represent the world's oldest living culture and continuous culture. Their strength and resilience and interconnectedness with all living things ground us as we do our work in palliative care. So yes, welcome everybody. It's very exciting to be talking about technology and palliative care. And I think for palliative care nurses, I feel a sense of like excitement about the future of technology, but then also a sense of angst about it too. So I've got lots of questions for Antonella. And the way we're going to run today is Antonella is going to give us a presentation. And then we're going to open it up for questions. So I'll give you a little introduction on Antonella. So Antonella is the Chief Nursing Information Officer at the Peter MacCallum Hospital. So she's got 15 years of cancer nursing experience and more than a decade of clinical nurse educator experience. And she's contributed to lots of different types of educational and digital transformation projects. She teaches at Melbourne University, and we're very, very excited to have you with us, Antonella. Thank you very much.
Thank you. Thank you, Sarah, for that great introduction. And I'm also very excited to be here. Thank you so much for the opportunity and for inviting me to your Palliative Care Nurses Australia webinar series.
Now, Antonella, just before
Yep.
you go, I'm just going to say to everyone the basic ground um, housekeeping bits and pieces, which is keep your microphone off, but if you can, camera on. We don't mind if you're at work. We don't mind if you're in the car. It is way easier to talk to some cameras and people on cameras than a name. So take it away, Antonella.
No worries. So thank you. Um, as Sarah said, I'm from Peter MacCallum Cancer Centre. I'm the Chief Nursing Information Officer there. And that might be a role that it might be, the first time or, not quite sure what that's about. And that's how I was about 5 years ago when the role was first advertised. Um, and what it is, how I usually explain it is that I almost act like a bit of a translator between nursing practice and what nurses need and IT. So, we often, IT might come up with some amazing ideas that they think is going to be really good for nursing practice. And then what my role is to actually go, hey, actually, that might, it's not going to quite work in the nursing workflow or, at the bedside or with the patients. Like maybe think of it, maybe we could change this and, implement it this way. So I love my role, but it's definitely, I see myself more as I'm still a cancer nurse. I'm definitely not an IT specialist or anything like that, but I do have a pretty good knowledge around that so that I can help, both nurses and IT understand each other and what they need.
Mm.
Yeah, so apologies if you hear my cat meowing as well in the background. So I thought I can see everyone has got access to the chat. I just wanted to open it up with a little question first. When you hear the word technology in nursing, and as Sarah mentioned, what's the first thing that comes to mind? Do you get excited? Is it more fear or is it frustration? If you can just quickly pop one of those words in the chat just to get a bit of a sense of how people are feeling around technology. Yep. So Sarah, you've got fear as your number one. Nervous. Yep. Yep, that's a good one. Stephen's excited and terrified and nervous. Yeah, and I think they are very normal reactions and definitely that's the general feeling at the moment around in the sector is that there's a lot of excitement and lots of hype around things, but also just nervousness and worry around how is it actually going to impact my work or my practice. And I think that's because often when people think about technology in healthcare, they're often picturing machines, or if you've ever used one of those AI image generators, if you put in nursing and AI, it comes up with this kind of futuristic looking nurse with screens around her and no pens, algorithms. But really, we're still nurses. So at the heart of nursing, it's not about the technology, it's about the people still. So every new tool that's coming to us from stuff like that we're pretty used to, telehealth to artificial intelligence, I think there's a real tension between it pulling us away from our patients or freeing us up to be more present with our patients. And that's the key is, which way how are we going to go? Is it going to keep us away from our patients or actually free us up to spend more time with them? So today I'm going to spend a bit of time just exploring a general digital technologies, going to dive into a little bit into AI, and then how we can make use of some of these technologies in palliative care and nursing care, really, nursing practice. All right, so next slide, James. I think maybe one more. Yep. So I think we already know that before I dive into some more examples, we all use digital tools in our nursing practice already. We might not even realize that some of the stuff we're using is actual AI. Can everyone just give me an idea of what kind of things are people already using in practice? So what are you doing in your day-to-day? Pop it in the chat. What are some of the key things that you're already using? Telehealth, yep, that's a really big one. And didn't COVID really spur that one on? That it just totally took off. Yep, electronic medical records. Yeah, so I believe you guys have is it called Palcare, the electronic medical record that a lot of community, yeah, palliative care. That's fantastic. Copilot. So we've got some AI lovers here, which is good. ChatGPT, amazing. So people are already using it. We're really, especially telehealth, it's really becoming part of our everyday practice. EMRs is a really big one. And then using those large language models to try and help us speed up some research, speed up writing policy and procedure, things that might have taken us hours to do to make sure the grammar was right, we can now do in minutes. So it's great that you've already been able to use those things. So thanks for sharing. And yeah, really clear that we're already using lots of variety of things. So it sounds like you guys you already know lots around digital health. But I just wanted to touch base on, what kind of other things we include when we talk about digital health. So even things like mobile health and applications, so using SMS for messaging, different types of apps and mobile messaging, secure messaging devices, that's all part of our digital health. Around medicines, it might be electronic prescribing, electronic medication charts, might be barcode scanning. So if you've got some people in the webinar might actually be using barcode and digital scanning technologies to check patient ID or to check medications prior to administration. Electronic health records, but we've also got My Health Record, and that's actually a really fantastic piece of technology that the government is really investing a lot in at the moment. And they're trying to make it so there's some legislation that's recently changed around sharing by default. So pathology providers and imaging companies actually going to have to share. And if they don't share their images and pathology in people's medical record, who've consented and who've got a record, of course, they're actually not going to get paid for the services there. So the government's going pretty hard on making sure people are giving patients their own data in their hands. Telehealth, telemedicine, we know a lot about that one. We've either used it as patients ourselves or we've used it as nurses. Wearable devices, so I can guess probably half of us have some kind of fitness watch that tells us what our trends are. I got told that my fitness trends have really dropped off over the last 2 weeks. I had the flu, so I was like, come on, give me a break. But anyway, that's the trend that they identified. It was true. I'd stopped walking. We've got those kind of things. Robotics and AI, that it's still something that's really still developing for nursing practice. Electronic referrals, so lots of things that are already in place for us. Now, we can do the next slide. And the next slide, I might have. Oh, this is one of these silly, James, just go through. Yeah, that's it. And to the next one. So I'm going to jump
Technology,
into,
hey? Yeah.
yeah, into a hot topic. Now, there is no digital health presentation at the moment that doesn't talk about AI. What I wanted to start off with is AI. There is so much hype around AI at the moment. Is that wording not quite right on your slide as well?
Yeah, it's a
The
little
font's
bit,
gone
little
funny.
bit squished in, but does it say gather hype
Gartner,
cycle?
it's the Gartner hype
Oh,
cycle.
oh,
So when I share the slides, I'll change it to a simpler font so it comes out better. Um, so I wanted to share this because it's a cycle that people talk about a lot in digital health and technologies. And it's something that helps us just to understand how new technologies go through different stages. And one, we can probably all in our head, people have already said that they're using ChatGPT. So I'm going to use that as an example. So every new technology goes through this first stage, which is called the technology trigger. And that's that breakthrough moment for when people really gets people talking. So for ChatGPT, I think that was late 2022. Yeah. And that is when that really just went ballistic and it showed the public, what AI could do. Now, AI wasn't new. It's been around since 1950 in different ways, but ChatGPT really showed people, put it in the hands of everyday person for free. And it wasn't something, it's not very hard to actually use ChatGPT. So there was an absolute, exponential growth in the use. And that's when often things peak. So people get super, super excited, and then we reach this peak of inflated expectations because people just start thinking about all these crazy things that they're going to be able to use the AI for. It's in headlines everywhere in the news, and it was almost overnight. But then inevitably, we get to the trough of disillusionment when people actually start using it and realize, hey, it's actually, it's not, people realized that ChatGPT was making stuff up, hallucinating. Um, I wrote something once and it gave me references that totally didn't exist, authors that were not alive, like never existed, but it was so sure of itself that, if I wasn't um, with all AI and any of these models, we've got to make sure there's always a person in the loop. So, after actually checking what had been written, realized it was complete rubbish. So you kind of hit this rock bottom again and go, oh, hey, like that's actually pretty disappointing. I thought it was going to solve all my problems and it hasn't. So we realized that it's actually not going to fit that smoothly into our workflows if we think about it from a healthcare perspective. But I think where we are at the moment is this somewhere in between this trough and coming up slowly to the slope of enlightenment. So it's learning how to use these things efficiently, effectively, sorry, and safely. We've got an idea, we've played around, we've tried to do lots of different things. And through that, we're learning around how to use the right prompts, how to use the system to our, so it actually, and also the system that learns through us and through the inputs that we're putting in. So it is getting better along the way as well. But I think we're kind of along that slope. So getting to the plateau, not there yet, but still lots of learning to do. And then once people really learn how to use it, we know its uh, barriers and limitations, we get to that kind of plateau of productivity. And that's where it just is going to become normalized. It's going to become part of it just every day that we work. And we're seeing that with some of the other there's ChatGPT, but also Copilot, and that's been rolled out across Peter Mac as an approved large language model for us to use in our work. Sarah, I can see you've got your hand up. Sorry.
I do. And you may be about to say this to us, but and I don't know if it's possible, but in a couple of sentences, are you able to, for those that have been hearing AI and they're like, I don't actually know what it is, are you able to give us a quick, succinct summary? Just if there's anyone in the room who's thinking, oh, I've always wanted to ask, but I don't really know
Yep,
what it is.
totally. And that's my next slide.
Oh, great,
So
cool.
now, what actually is AI? So artificial intelligence. Um, I You wouldn't believe it, but this little image came from the NASA What is AI website. And I thought if NASA can distill this down into this little diagram with three circles, I think we could also learn this and explain it and understand what's going on there. So AI at its core, it's about, if you think about it in a way, it's using computers to do tasks that would normally require some kind of human intelligence. So like recognizing patterns or making predictions or summarizing information. Um, it's so it's not, sometimes people go, oh, so it's actually something it's actually intelligent, but no, it's artificial. It's not real. It's like, it's kind of working in the neural processing ways that your brain might be working, but it's still a computer that's been programmed and lots of algorithms and rules behind it that is able to mimic some of that human intelligence, but it is missing a lot of human aspects such as empathy and compassion and um, things that make us human. So it's more like the intelligent part, but not, I guess maybe the IQ, but not the EQ. The emotional intelligence is definitely not there. Even though ChatGPT sometimes it sounds like it's very emotionally intelligent, but it's still a machine and a computer doing that. So the big bubble is your artificial intelligence, and then you would have heard maybe people talk about machine learning, and that's when it uses algorithms from data that it has in the system to make predictions based on the data that's there. So an example in cancer care, We have a sepsis prediction algorithm that we use in our EMR. So it has got to build the model, you've got to input thousands and thousands of patients' physiological data, lots of different data points in there. And then from that data, the machine can learn what are the patterns that will give us the most accurate prediction that the patient will get sick from sepsis. We also use it for, you can use it for other things like work. So in the emergency department, they can actually at the Royal Melbourne Hospital, they have a really cool, if you go on their website and you want to know what is the waiting time for a patient in emergency right now. So they don't just say it's green, red, or green, orange, or red, long wait to short wait. They've actually been able to give you how many minutes you're going to be waiting. And that's based on machine learning of thousands and thousands of days worth of data of patients that have sat in ED with mixture of presentations, and it then predicts what the patients that are in the system right now, looking at the electronic medical record, what is the prediction for how long they will be in emergency. So it's really using lots of rules in the background. And also often those models use, they keep learning from new data that's coming in all the time. Natural language processing, gathers. Yes. Yes, Peacock that is amazing data quality and like data gathering. We use that in our electronic medical record, so the nurses are completing that every day. At the moment, we're not using that in any way for predictions of deterioration or symptoms that might be changing, or prediction of maybe you could use it to actually try and predict how long
Yeah.
the patient will be.
So my question for those
Mm,
that are who didn't see what I wrote in the chat was I just said palliative care gathers so much data through Peacock, good data, and I wonder just having heard what cancer nurses are doing in terms of sepsis and emergency departments, and I wonder whether we could be using that data to help us predict things,
mm.
right? Or to anyway. So that was just my thoughts, but it's very interesting, Antonella.
Exactly. And I think you also bring up a really good point is that I think for us to remember that for AI to work well, we actually need to have it's the data that is key. So if we have poor data in the system, the AI is not going to work as well. So if your data is inaccurate, if it's not contemporaneous, if it's missing data points, that's all going to result in a model that's not working as well as it could if we actually had really good data quality. Um, then what else we got? And then the deep learning is even, I guess, simple way to explain it is getting even more complicated. So being able to predict more, generate new information entirely, like new content. One cool thing that we're going to be trying to pilot at Peter Mac, and that's using machine learning and computer vision this is to to predict patient falls. So not just a falls risk prediction, but we are going to have pilot a camera that is monitoring the patient while they're in bed or in a chair. So it's completely de-identified and like a ghosted image. But the system has been trained on thousands and thousands of images of patients sitting in bed and then making attempts to get out of bed. So it can actually predict what kind of movements mean that patients just rolling around in bed or turning over as opposed to trying to get out. And then the idea is that it'll send a notification to the nurse's phone that's looking after that patient, and they can get a little image of what the patient is doing in the room at the time and can actually talk to them and say, hey, Mr. Smith, I'll be in there in a minute, just stay in bed, don't get out. that all well and good, if they can understand what you're saying and they're not delirious. But that's something really cool that we want to pilot, as opposed to waiting until they've stepped off onto a falls mat, and by then, they've already had the fall.
Mm.
But we're trying to prevent them actually getting out of bed without supervision, if that's what they're supposed to be doing. Did you have another question, Sarah?
Oh, no,
Where are we
no.
going? Oh, good. Yeah.
No, well, actually, what strikes me is
Uh,
I think it's a tool to help us, right? Like, and we don't even really know what it doesn't need to be something that we need to be scared of, right? Yeah, it just strikes me that this is something that actually can help us very much so, but just it has to be in the right, you thought it all in the right way, I think.
yeah, I think that really is the key. It's around, and I think sometimes we can get nervous, but also like super excited about new technology, and then tr want to try and implement it somehow. But you really have got to understand, like, what is the problem? Like, what is it that you want to solve with
Mm.
technology? And then trying to find the right technology for that problem, as opposed to the other way around, where I've seen that happen as well. People get really excited about some shiny new thing and go, well, which ward can we just turn this on in? And you're like, well, hang on, it doesn't quite suit the patient population or the nursing model of care, or, it's a great product, but it's not going to work for us. So it's being able to assess new
Mm.
technologies and understand, how is it going to work? Does it actually solve our problem? Or is it just exciting, something pretty cool just to try, but it might actually end up giving us more problems than solving the ones that we need solved. Yeah. Because we did look at like better falls risk algorithms. But then we realized, like, most of our patients are high falls risk. It's around the interventions and helping the patient, like having enough people to respond when that's needed. We know everyone's high falls risk. Let's stop, spending a lot of time around that. Actually put the interventions in. So we're hoping that this will help, so that, and also just to help, because our nurses were saying they were really, after a fall, they actually felt pretty bad. Like, their
Mm.
well-being, they felt guilty that it was their patient that had fallen, but they'd been busy with another patient that was very, very unwell. Or on some of our wards, we have palliative care patients that nurses are looking after alongside a patient who's needing, life-saving chemotherapy. So it, we're hoping that this will help them feel like, even though they might not be in the room at the time, they're going to be notified when they need to go. Like, it's time to go and see your patient now before they fall. So yeah, I think that's all. The next one is, I've actually got a little video that talks about generative AI.
The next slide, is it next
Yeah, the
slide?
next slide. So I hope, if you press play, this video goes for 3 minutes, and it shows, we use the electronic medical record called Epic, and these are some of the AI functionalities that they're already using a lot in the US, but we haven't launched it here because we're still working through a lot of governance, data privacy, and security for an Australian population, seeing we're using a US product. So there's a lot involved there. Also working through the costs. But I think this is good. It just gives you a bit of an idea of how generative AI can be used within the patient's medical record. So James, do you want to see if that plays?
Mm.
If you, I think if you click play on the actual
Middle.
middle, should work. Uh, and when you did share, you've just got to say share with sound.
Think we might have a little issue with sharing this given the settings.
That's okay.
Okay, we can.
Could we
I'll
add it?
send the link through with
Yeah,
the recording. Sorry, everyone.
Okay.
and we can pop it in the chat even. I'll
Oh
find the link.
yeah, yep. So this just talks and gives us examples of, it's kind of like using ChatGPT, how ChatGPT works, but within the patient's medical record. So one of the examples is for nurses is at the end of your shift, there's lots of documentation that's occurred throughout the shift.
Tara is the IT painkiller. Remote monitoring and management, remote access, help desk and ticketing.
I played it on my computer and I got hold on.
Scripting.
Sorry.
And the amazing thing is that it does.
Okay. Sorry, everybody. Continue on, Antonella. I'll stop playing with my computer.
So one of the use cases is that they're doing summarizing the end of shift note for nurses, so that they're, throughout the shift, they're documenting in the right places. They might be documenting their peacock data. And then with the click of a button at the end of the shift, it actually summarizes all the documentation that's occurred throughout the shift. The nurse then reads, adds any additional context or things that have not been documented directly in the chart. So for, that might be a really important conversation or family meeting that was had with the patient. So it means that you've saved a bit of time in documenting and synthesizing what you've done that shift, and then you can concentrate on anything additional that hasn't already been documented in the chart. The other way that we want to use it in the future, and I can really see a palliative care use case here as well. I don't know how many like hotlines there are or after hours where people can call up a hotline and receive support that way. But we are going to be able to summarize the patient's journey or what's happened to them in the past for the person taking the phone call, because they might not have ever met this patient before and they're trying to work out, hey, what's happened, what's the plan, what medications they're on. And we find that our after hours hospital coordinators always struggling and sometimes just miss information because there's so much to try and go through in the medical record. So with the click of a button, you can actually get a little summary of diagnosis. This is what's happening, the medications, this is the last visits. And they've done some research around this in the US already, and they found that people reported that in 20% of those generated summaries, that there was information in there that they would have missed otherwise because they didn't know where to look or they didn't have time to sift through the chart. So that's helping us to be able to get that complete comprehensive picture of the patient. And that's that one. Then I had another video, but that's okay. This one, actually, yeah, this ambient listening one probably won't work either, but ambient listening is another way that something that we want to pilot for our nurses is you're go into a room and we're assessing a patient, you're having a conversation around, how doing a physical assessment, head-to-toe assessment, for example. You can actually use some kind of device. So we've got devices that each nurse carries. You tell the patient, I'm going to be doing an assessment, get consent to record the interaction. And in the background, the device is recording and listening to that interaction. And at the same time, it's actually documenting things for you in the right place in the chart. So you might be doing a pain assessment. Patient says my pain's 5 out of 10 in my lower back. It's worse on movement. It's actually putting that in the right flow sheet or whatever the electronic medical record is called. It puts them straight in there and it summarizes that conversation at the end so that you're able to actually do that assessment without having to write or type at the same time or trying to remember everything that's happened. But you get that summary at the end, which then needs to be confirmed that it's accurate and hasn't missed anything, and also just double checking that the findings have been placed in the right place in the chart. We need that yep. Yeah, so I can really see, imagine seeing your patient at home and not having to worry about doing that documentation at the same time or doing it afterwards, which, adds a lot more time, but it's doing it at the same time and doing a nice little summary for you.
It really will be, when that happens, it really will be like work change, right? It will give it, instead of spending an hour doing the admin that's required for a patient. You can spend that with the patient.
Yeah.
Amazing.
Yep.
I guess my question for you, Antonella, is so say everyone who's listening to this now, yep, totally. We need this. This is what we need to be working towards this. What's your recommendation for how do we, my feeling is that we're not there yet, right? Like, and we're not, our services aren't even thinking about it, or not seriously. How do we kind of edge our bigger people
Yeah.
like to this direction? How do we start the conversation so that it's something that we start thinking about properly?
Hmm. I think probably the first step is actually gathering the data now. So documenting how much time are you spending in documentation. So every day collating that information, and that's data is really powerful in showing like if you see that you've spent 5 hours documenting that day and a piece of technology might save you an hour or 2 or 3 hours or even half an hour over the week, that's 2.5 hours if it's half an hour a day. So start gathering the data now and thinking about where are those potential opportunities for improvement, for efficiency, for just giving me back some time so I can actually have lunch. So it might be around nurse well-being, that
Yeah.
it means that you can get back into the office and have your break, or on the other hand, you might be able to see an extra patient if someone who's really unwell and otherwise might have had to wait till the next day, for example. So really start collecting that data and
Yeah.
talking to your leaders around it.
It's about, so you were saying kind of articulating the problem, right, with proof, and
Mhm.
then finding the value. What would it, how would it improve things? That's, thank you,
Yeah.
Antonella.
Stephen said in there, our service is currently actively discouraging it. And look, I'm not surprised, because I think there are lots of myths and concerns around the use of the technology, which is very valid. So these are things that just need to be worked through. And if there is something that I'd probably start off with thinking about, what can we do, a small pilot, actually just try, if you've got the capacity to do that, try it. A lot of these companies actually do free pilots, and they'll give you the software for you to try for a month or something. So give that a go and evaluate it. See, did it actually help? Was it more of a hindrance and it was annoying because you had to just keep worrying about the tech? Or did it actually work and it saved me, X amount of time? So if there is opportunities, talk to your leadership, try and pilot things, do research on it, evaluate it properly at the end. And we've had a few pilots, or we call them proof of concepts, where we knew within 2 days that it just wasn't going to work. And we just had to pull the pin and go, okay, we gave it a go. It's always better to try and to fail than to ever not even try at all. That's kind of a bit of our mantra. And we're very happy to say it hasn't worked and we're going to try something else. Um, yeah. And get involved. So if you can, get onto that working group, get onto a committee, or start, form your own little community of practice that's around digital health and talking about these potential pieces of software or something that you could actually try. Yeah, so that's a good video if you want to have a look at how it actually looks in like a consultation.
And I've added the link to that into the chat.
Okay, cool.
Yep.
So next slide, please, James. This is, sorry, I couldn't get the QR code to work for me. But if you're interested in just learning around, so Australian College of Nurses has released a position statement around the use of artificial intelligence and for nursing. So it's very nursing specific, and it goes through some of the key considerations that if you're thinking about using it, or if you're already using something like, ChatGPT, it just talks through all those things that you need to be aware of around privacy and confidentiality, ethical use. So if you just Google that, you'll find the PDF document of that. Now this one is, I found a really cool paper around, it was a scoping review of digital health technology applications in palliative care. So that's the reference down the bottom, and it's a really, really good summary around what's already in use nationally and internationally. There was a lot around symptom tracking, so like vital signs, mood, or activity levels. And you might hear the word PROMs used, so patient reported outcome measures. That's where the patient is actually reporting their symptoms, or usually their symptoms, through an app, which is then sent to a health service or community palliative care, and then someone's responsible for reviewing and escalating any results that come through. So that this is something that's absolutely, like, it's incredible, the potentials of PROMs and patients reporting information in real time to you is just, yeah, incredible. But where we are lacking at the moment still is around like models of care, and how do we actually implement this on the other end? So the nurses responding, and what happens in the middle of the night or on a weekend when there's no one on. So we haven't actually been able to implement. We've piloted a few PROMs through our patient portal, and every time we've come unstuck around the workforce, because we're currently, the way our models of nursing care are in a hospital, it's very like inpatient or Monday to Friday 9 till 5 based, and you've really got to have a 24-hour kind of response service for this to work properly. Lots around like educational videos and information provision. So I think sometimes we forget that, yeah, digital health is actually, it's education for patients as well. Decision support. So that's when within an electronic medical record, you, or any kind of electronic system, it alerts pop up at the right time, maybe to stop you from doing something unsafe, or there might be like an interaction, lots of different ways that this can, but it's to support you in making decisions in clinical care. And really cool one that we're actually using at Peter Mac is virtual reality enabled psychological support. So we're actually using it for our palliative care patients, where we can bring in virtual care goggles and they can go and see the Taj Mahal or go to the Eiffel Tower, go to New York, you know, and just act as a bit of a distraction. Next slide, please. So the key, they had some really positive results around improving pain management, symptom relief, quality of life, and psychological well-being. There were really good levels of acceptability and feasibility from the patients. And many patients completed, yeah, like it was actually, even though sometimes we might be quite protective of our patients and think, you know, like, I don't know if they're going to want to use the digital technology, the uptake was actually really, really good. And patients, you know, most of our patients have a smartphone or have the internet, so they're pretty savvy with digital technologies as well. And next slide. So some of the challenges was around the complexity of technology. So VR is great, but you've got to have the goggles and all of those things, which can be quite expensive. So it's often not something that you can do in the home. A lot of the research is still very early stage. And as with everything, there's always privacy and security concerns from clinicians and from patients. And then some of them are it's a bit hard to personalize or to customize. Next slide. So if you want to read into that a little bit more, just look up that paper. And we can go to, now I wanted to just highlight that we have something called the Australian Digital Health Capability Framework for nurses and midwives. And you can go to the next slide. So you can look that up. It was developed with all of the key colleges in Australia. And the purpose of, so you can use that QR code to find it. And James, also, if you want to go to the next slide, the purpose of it is to define digital health knowledge, skills, and attitudes that are required for professional nursing practice. And that's in all areas of nursing. It's to complement any existing knowledge, skills, and attitudinal frameworks, so all of our NMBA and APRA frameworks that we need to work within. And it gives people a solid basis for understanding what additional learning they might need. So if we go to the next slide, it's set out in 5 different domains. So around leadership, advocacy, data and information quality, information-enabled care, technology, and then digital professionalism. And that's a cool little section because it also talks about social media and where we stand around like using social media as nurses. And then each one of the domains has certain points that help you. So if you want to have a read through it, you can see how your skills and confidence is around each of the domains. And then at the end, I've got a really cool resource page where you can actually, if you find that, actually, I think I really don't know much about data and information quality. If you go to the next slide, yep, so it's all set out in each domain has got different levels of skills you might need at a formative, intermediate, and a proficient level. So someone in my role should be proficient in each of those, but if you're not working in a specialist digital role, you'd want to make sure that you've got formative knowledge around all of those different domains. And they're actually using this capability framework for undergraduate teaching as well, because we want all our undergraduates to actually be able to graduate and to hit the floor running when it comes to using digital technologies in their practice. And next slide, please. So there are all the different domains and capabilities in each one of those. And next one. So if you want to learn more about educational resources around digital health, look up this web page. It's got a whole heap of free MOOCs, so massive online courses, which a lot of them are for free. So you can do lots of free learning that way. There's little modules and videos that you can look through as well, but that's a really interesting, and most of it's free, which is good. And next one, I think so that comes to the end of all my slides. Sarah, so happy to take any questions.
Yeah. So firstly, thank you very much. That even just that little introduction kind of blew my mind about the possibilities and made me a bit excited and a little bit fearful all at the same time. But so I guess what I'm going to give everyone who is listening a chance just to come up with a question and pop it in the chat. And I'm going to pop out a question that I think is important so put some questions in the chat for Antonela, and I'm going to ask my question, which is, I think, and you may have answered it at the start, I guess one of my worries is when technology is, so I worked at a service where telehealth was pushed really hard, and it kind of was used in a business way to get us to see more patients, and it kind of took away the heart, what I felt like was the heart of what we were doing, which really was, palliative care really is about connection, and it's about present relationships. And I guess my question to you is, how do we find that balance so that we don't, as palliative care nurses in particular, lose the heart and the art of what we do?
Yep, that's a really good point, Sarah. And I think we've just got to stand strong and firm in what we believe is at the heart of nursing. So it's nursing care, it's person-centered, it's often, especially in palliative care, like you said, it's hands-on work that no piece of technology is ever going to be able to take that away. So it's being aware of that and pushing back when you feel like it's actually not in the best interest of the patient. So I guess if we always just bring it back to the patient, and there might be I'm sure, lots of cases when telehealth would actually be really good for the patient. So you might be able to do that family meeting or, whatever to stop people having to come from rural areas or, so there's really good use cases, and maybe, the odd check-in is fine, but, and, understanding that. So I think for me, it's like advocating for our patients and our nurses, what is the best for them, and not getting too, like I said before, caught up with that shiny new thing. And ultimately, like, even though that might have been a business decision, but if we look at the data, I'm sure that if there was a good evaluation of that, did it actually mean that you could see more patients? Did it actually end up with that, or did it
No.
mean that there was times when it was totally inappropriate to have the telehealth and someone still had to go?
In the end, we were seeing the same amount of patients, but just via telehealth, which was really sad, right?
Yeah, yeah.
But what actually the take home from that for me is that that piece you said about data, right? And gathering the data about the problem and the value that it's adding, right? Because I think that's a tool that's very useful in this piece. Now you've answered my question. I'm going to read out what Steve's just said in the chat, and then Liliana's got a question. Is that okay? So Steve said,
Yeah.
I agree with the comment that it doesn't replace the human element. One, you need to read through the output to make sure it's accurate and pertinent. It doesn't replace the clinician's, I can't say that word, phronesis, very clever person. Steve, or practical wisdom. Oh, yes, I know what that means. Yes, it doesn't replace the practical wisdom and is not about the knowledge, but it's about the application of knowledge. Yeah. So AI should be seen as something useful, as a useful co-pilot only. Yeah, we're working together. It's not replacing us. Yeah, exactly, Steve.
Yeah, yeah. And with any AI, I think, especially now, like maybe in the future, it'll be different, but now you've got to have a human in the loop.
Yeah.
There should be no AI that is running off on its own without a human checking in constantly and never, signing anything for us, or, there always has to be that. And also it's a legal thing. Like, if something comes back, it's not ChatGPT that's going to be in trouble. It'll be you, because you've signed that note, even though you might have had some assistance from Copilot and it hallucinated. So it's still, we're still accountable for our professional practice, even when we're using AI to help us. So exactly, it's there to support us and to help as a co-pilot, but not to take away from.
Thank you,
us.
Antonella. Liliana, did you want to unmute and ask your question, or has that gone away now?
It wasn't so much a question. It's more of a just comment around what I agree with Steve. I think it's not to replace. It's definitely got its place. But I guess it's when we're talking about before about the quantity of interactions via, say, things like telehealth, that doesn't necessarily show the quality of that interaction. I think that's the dangers of AI. I think it's really good when used appropriately. And I think there's a lot of literature out there. I recently just looked at some literature around telehealth for an outpatient setting. And while there is some evidence of how good it can be, the actual assessment required within the palliative care specialty is very much limited, and you can't really, it can probably impact the advice given in that interaction. You do need that person face-to-face value. Yeah.
And there's so much you can gain or, gather from being in a patient's home with the carers and the body language, things that, you just are not going to capture, especially, you know, sometimes people use telehealth just phone, so it's not even video. So that's, you're not even seeing them face to face, but not even seeing them on a screen. You know, I think that's suboptimal, really.
And Liliana, I like what you said about, I think it's the quality, right? We need to be getting the data around the quality of the interaction, which is very, very difficult to do, right? But then also the level of training to do that type of assessment. So if we're going to expect our nurses to be doing telehealth, then how are we training them to do that quality interaction, right? It's not so much about using the technology, that's a part of it, but it's actually developing that kind of phronesis, you know, that practical wisdom, that rapport building, right?
Yeah. And I think that's what Antonela brought up about the PROMs, so the patient outcomes, but also the patient experience. So I think there is some things going on in the background around looking at patient reported experiences, and perhaps that integrating the PREMs and the PROMs within those sort of settings, along with some AI technology, could potentially be that perfect mix. But I think we need to really focus on maintaining quality.
Yeah, thank you.
And I would just, one more thing just to add is, you know, if you can, when there's ideas, people want to implement something, it's very quick to spend the money on the, you know, they want to spend the money on the technology and the implementation, but an equal amount of money should be spent on the evaluation of that, and qualitative, not just the quantitative. So, you know, some kind of mixed methods. I'm really trying to push back in my hospital that it's around making sure that, and because this is all new, like we want to actually be producing the evidence. And if it doesn't work, like that's just as powerful to publish as something that's really cool and has had a good outcome. But people want to know, like, why didn't it work? What were the barriers? What, you know, how can I actually learn? So if we want to implement that, we can, you know, change it up and have it actually work in our health service. But yeah.
Thank you so much, Antonela. And I'm conscious that we're at 4 o'clock. I think we probably could have kept talking about that for another hour. And maybe we need another one with really targeted questions, because gosh, it was interesting. I'm actually a little bit excited, and I'm grateful. And I reckon the people who are here now have got these little ideas bubbling, and we're all going to go off and feel passionate, or at least less scared, maybe.
Yeah. I hope there's a little bit less nervousness, but
yeah. So look, thank you very, very much, Antonela, for your time and your exactly as your role. You said there's like the technology translator. Thank you for translating the technology to us as palliative care nurses.
Thank you. Pleasure.
Yeah.
Thank you for having me.
And look, and so that there is no webinar in the next 2 weeks because there's a conference. So hopefully I'll get to see some of you there. Please come up and say hi, because I'll know your names, and I feel like I know you all, but I want to talk to you in person. So thank you, Antonela. We're very grateful for your time.